couple of my lectures deal with treatment patterns in patients with non-tuberculous microbial lung disease in general and pulmonology practices in Germany. My name is Microbiology and I work for an biopharmaceutical company. This is my disclaimer. I will give a short introduction to NTM disease before moving to research. In 1882, Robert Koch identified the cause of tuberculosis called Mycobacterium tuberculosis. Ever since, related Mycobacterium species were identified and they were called non-tuberculous mycobacteria. In the late 1950s, NTM were widely recognized as the cause of human disease, and ever since new species have been identified, and over 190 species of NTM are recognized as of today. NTM is present everywhere in the environment, and through swallowing aspiration, you come in contact with NTM. And transmission results from environmental exposure as opposed to human to human. However, only few individuals actually develop clinically relevant disease. NTM is a rare disease, however, it is emerging globally because of increased prevalence observed throughout various regions. The typical NTM patient would suffer from chronic recurrent cough. Weight loss is common, fatigue, fever, chest pains, infection. These patients are by far already an underlying pulmonary condition, this NTM infection on top can complicate and significantly increase patient morbidity. Studies have shown that it can increase mortality. It reduces patients' quality of life and presents as Now, the way NTM is treated, it involves multi-drug regimens that should be administered over 12 or more months. There are guidelines that specify a combination of drugs that are applied, and these are drugs that have been taken from treatment of tuberculosis, such as rifampicin, tambutol, and in the beginning of 2000, also microbiology. The objective of the research was to analyze the baseline characteristics and management of NTM in general and pulmonologist practices in Germany. Going to results, we used IMS Disease Analyzer as a data source. This is a database of electronic medical records that are collected in practices and capture data on patients' diagnosis, on prescribed therapies, laboratory test results, and referrals and hospitalizations. We identified patient population through the ICD-10 codes, which are listed here on the left in the corner. So we also specified what guidelines-based therapy is, and we saw that we can identify approximately 400 patients in the database with 160 patients approximately in GP practices and present pulmonology practice. The baseline characteristics of our patient population are shown in the table here. The mean age was approximately 60 years. So what we could see is that the majority of patients already have some chronic lung condition, such as COPD, or they have tuberculosis, or bronchitis, or asthma. And presence of those chronic pulmonary conditions are higher in patients that were treated by pulmonologists as compared to general practitioners. When looking at how many patients actually received antibiotic treatment, we see that less than half of patients in either GP practice or pulmonologist practices received treatment. And those patients, when looking at those patients who were treated, one can observe that only 1 out of 4, approximately, in GP practice received guidelines-based therapy. This was somewhat better in pulmonologist practices, but nevertheless far from what would be an ideal treatment. Looking at first diagnosis to onset of antibiotic treatment, the treatment, if start immediately after diagnosis. However, there are some patients in whom treatment starts later. There will be patients who, at least in this follow-up period, were not treated with antibiotic treatment. When looking at treatment persistence over time, we saw that there is treatment continuation. So patients stop treatment prematurely, and by month 6, almost 60% of patients will already stop their treatment, despite recommendations being that treatment should continue for at least 12 months. We saw that in GP practices, patients were treated on average 113 days, which is more than double in pulmonologist practices. There are common therapy switches that were observed, and for patients who were treated longer, we saw also a higher number of switches applied, which shows that this therapy is complicated. Patients probably do not tolerate the drug, or or resistance develops, or simply because the drug regimen is not effective, physicians tend to then switch therapies. First, having to provide insights into the management of NTM in general pulmonologist practices in Germany. Many patients were not managed in accordance with the relevant guidelines, and many also discontinued therapy. Medication being through management appropriate referral pathways and collaboration between private centers and primary and secondary. Thank you.